We start now. Good evening, everybody, and I'm Sachin Kulkarni, and I'll be presenting to you on male factor infertility. We specially named it as clearing the clutter because I'm really not going to go step by step telling you all the causes of infertility, male factor infertility, giving you treatment protocols for everybody. We're not going to go that way. And a small agenda which I've decided upon is we will look into a second look we will give to the routine semen analysis, which is the foremost test we do in our practice. We'll also talk a bit about azzoospermia, male oxidative stress, DNA fragmentation. We'll also understand 2 or 3 meta-analysis which have been published into male factor assessment and treatment, and the sperm selection which we should practice. So I would be jumping ideas, and you may feel that this is little apple and oranges, but we'll just tolerate that part of it because we need to cover a few topics which may be interesting and different to our way of practice. But the way we do semen analysis, which is the first test of our male factor assessment, and this is one stupid practice which we do, wherein a test recommendation is the first thing we do. We don't take a history, we don't go for the clinical examination, we just recommend a semen analysis, and as if the semen analysis is going to reflect every clinical parameter of that male, which is not true. And this semen analysis, all of us, we followed the 2010 guide. And in this guideline, there were about 2,000 men of the countries were selected, and the time to pregnancy, the semen analysis was done, and those who obtained pregnancy in less than 1 year, they were considered to be having the semen. The 10th percentile of it was 15 million. So that's why we consider 15 million and more be the lowest parameter. Anil, can we just switch the mute to rest of the speaker because there are some sounds I'm hearing there. And then we classify semen analysis into normal, abnormal, and obviously your. Even I have muted. You muted me.
No, that's fine. You're non-muted. You can go ahead.
Yeah. And but sadly, this semen analysis does not give us the prognosis to pregnancy, and the choice of corrective treatment is also not suggested by the report. And Christopher Barat, in his, I think this is one author we should follow. All his presentations on andrology and male infertility, he's really presented some fabulous papers. And what he says is how robust is our initial assessment, that is our routine semen analysis. And if you look at the semen analysis, as the sperm count is lesser and lesser, we are more specific towards our diagnosis, and our diagnosis and the outcome of treatment will correlate with each other. But is there much of a difference for somebody who is 20 million, 30 million, 35 million, and for that matter, 60 million? Probably all of them, we just say normal, and we go ahead in for the care of this patient. And this is a selection which was done at 271 laboratories in UK, and this is the NEQS data, wherein they made aliquots of the same semen sample, and it was sent to all these laboratories, wherein an assessment of the semen parameters as per the WHO 2010 guidelines or the practice of that laboratory was done. And see the difference. In the same sample, they have been reported right from 20 million to 72 million. Various laboratories have given various reports. So do you trust your semen analysis report? And most of us will say, well, no, we may be repeating the semen analysis very frequently. And then you are right there. Because this is another study wherein one man was supposed to give semen sample twice a week for a period of 2 years. And see this amount of variation in the semen analysis reports. He has gone into oligospermic zone very often. And few of the counts have shot up all the way to 160 million as well. So this just tells us that we wouldn't rely on one semen analysis, and we would be repeating the semen analysis 2 or 3 times and to know the trend and to come to a conclusion what is the report from the WHO 2010 criteria. Again, when it comes to diagnosis of male infertility, once the WHO 2010 was published, this was another publication which came in later. And they said, well, there are 2 ways people are presenting their data. One, the scientists are presenting, it is the prevalent experience of infertility in the men. And the most commonly it is presented male factor data is proportion of the total infertility, which is attributed to the male factor. And when in this paper, which assessed the semen morphology, motility, and the concentration in infertile men, they found that, well, infertile men and the fertile men, when it comes to the parameters of morphology, motility, and this concentration, well, it's not much different. Somebody who is 30 or 40 million is also infertile, and somebody who's 10 million is having 2 babies. So semen, then a lot of us may think that it is a very surrogate marker of fertility, largely depends upon the female factors which are there. And this paper came out with another set of classification, and this probably is to be considered by all of us. And it says that they said there's some fertile range on their data, and the fertile range is the count is beyond 48 million, motility is beyond 63%, and the normal morphology is beyond 12. And there's a fertile range which is less than 13.5 million concentration, motility less than 32%, and morphology less than 9. So you have a fertile and subfertile groups determined, and the in-between thing would be an indeterminate group. We really don't know whether what will be the prognosis of these patients. And then there could be a hidden male factor in the whole thing. So do we really classify, when it comes to unexplained infertility, do we say you have an unexplained male infertility? We just say it's an unexplained infertility with the whole couple. And what has happened is most of the research has been concentrated on the female factors, and we really have not investigated enough the infertility factors of men with idiopathic nature of abnormal semen parameters. And there will be a lot of men who are struggling to get pregnant, achieve their pregnancies in the spouse, but they have normal semen parameters. So, and then there is a paradox, because when it comes to male factor infertility, any discussion, don't you think it just comes to your mind, well, what is there to discuss in oligospermia? Give some treatment. If it doesn't, go for ICSI. So we rely heavily on ICSI, and the ICSI has become a norm for your male factor. And we really don't go into the idiopathic nature of it, or try to know the etiology and try to correct the etiology so that the male can achieve his own pregnancy. So we practice universally ICSI, but then that doesn't give any treatment to the infertile man. And this ICSI is but in manipulation of the gamete. So what the problem is in this, the women are carrying the treatment burden of the male factor. It's really hell for a lady to undergo repeated ICSI cycles for husband of count of 2 million, and we are unable to offer any particular treatments to improve this 2 million and achieve a natural pregnancy for that particular couple. So ICSI popularly has affected most of the research in male factor management epigenetically, but we have to consider the other factors also. Epigenetically, men with low sperm concentration have early death risk, especially death risk in Azzoospermia. It has been proven beyond doubt that the odds ratios are beyond 2. Children born after older men, so men beyond 40 years, if the sperm is used even for ICSI or those for natural conception, they have longevity problems. And this is published as recent as 2019 publication. So we come to this parameter, total motile sperm concentration or total motile sperm count, as a better parameter than your routine semen analysis, which indicates the severity of the male factor and also will give you some prognostic information. Total motile sperm concentration is the volume into count into total progressive motility divided by 100. And semen characteristics as per WHO criteria have not correlated with spontaneous pregnancy. And when it comes to TMSC categories, you classify into 1 to 5 million, 5 to 20 million, and more than 20 million. And these who are 1 to 5 million are the ones who would be going for their IUI as an ICSI, and beyond 20 million are the ones who could be correlated very well with spontaneous pregnancy outcomes. And when you look at the morphology, there is really no statistical difference in pregnancy rate with sperm morphology less than 4% or more 4% when it comes to spontaneous pregnancies or IUI cycles. But so let this not be, just because the morphology is low, let this not be the sole reason for you to think of ICSI. Now let's jump over to azzoospermia. And I'm going to present to you a very logical approach of evaluation of an azzoospermia. Before going to azzoospermia, let's understand where is semen in the body. There is no semen in the body. Semen is the last substance which is ejaculated out, which is just a mixture of testicular secretion, seminal vesicle secretion, prostatic secretion, bulbourethral, those secretions are just coming out. Out of it, the seminal vesicles contribute to about 80% of the secretions. And these seminal vesicle secretions are alkaline in nature, and that's why the semen is generally alkaline in nature. The one which comes from the prostate is about anything around 13 to 33%, and about from the testis is about 5 to 10%. So very small contribution of secretion is from the testes, but that is the concentration which has all the sperms in it. The testicular secretions are acidic. But since the majority of the semen comes from the seminal vesicles, the semen as such is alkaline. So if you have azzoospermia, azzoospermic male, if the semen volume is less than pH is towards acidity and there is associated azzoospermia, there is possibly a obstruction beyond the seminal vesicles. So this could be either a congenital bilateral absence of vas difference, it could be bilateral ejaculated duct obstruction, or it could be absence of seminal vesicles. And fructose test in today's era is really not necessary. But then you will have patients who are having normal volume azzoospermia, so a semen volume beyond 1.5 ml. And this could be non-obstructive azzoospermia because of spermatogenesis failure. So testis is not contributing. It wouldn't make a difference to the whole seminal content because seminal vesicles are contributing. There could be blockage at the vas. So there could be a blockage before the seminal vesicles, at the vas or the epididymis, and that could be leading to a normal volume azzoospermia. And herein, a clinical examination can make a difference. If you have a small soft testis with non-obstructive azzoospermia, well, that could go to a spermatogenic failure or primary testicular failures. And normal firm testis could be an obstructive azzoospermia. And obviously, if you do a sonography, and if you say with the vas and epididymis, this is obviously clinical also, but sonography, most of us in gynecologists could be doing a sonography. And if it is normal or full, then there could be an obstructive azzoospermia with a normal volume, obstructive normal volume azzoospermia would be there. What about the FSH values? I'm sure all of you in your azzoospermic patients are doing FSH values. When the first study was published, the normal range of FSH values with normal semen parameters was between 0.95 to 11.95. So do you want to say, when we have such a wide range, for somebody who having an FSH of 2, an FSH of 6, an FSH of 11.90 are all having a normal males? Is that wide range? And if you have to plot a curve, we expect the curve should be like this, a typical bell-shaped curve. And then the mean value of the FSH level would be anything around 6 to 7 MIU. And you'll say, well, this is what the FSH of the normal semen analysis male would be. But that is not true. The real picture is, the curve is like this, wherein the most of the men with normal semen analysis have an FSH value mean of 3.37, and there is a tail, long tail, which extends all the way to about 11 to 12 MIU of FSH. So then, when you have an FSH value of 2 to 5 MIU, that could be more normal compared to a value between 6 to 12 MIU, and that could be still abnormal with the semen analysis report. You need to correlate that. And in this particular category, when you have a higher FSH value, the clomiphene alone may not work in these particular group of patients. We are going to come to that a little later. The next question is, do all patients of non-obstructive azzoospermia have a high FSH value? Can FSH level be normal in non-obstructive azzoospermia? We should realize that FSH is not from a testis, it's from pituitary. And that is regulated by inhibin, which is secreted from the testis. Inhibin has two parts, the A and B. The inhibin A comes from the Sertoli cells, but the inhibin B comes from the germ cells. So when you have a non-obstructive azzoospermia of a maturation arrest case, the germ cell population is there. The meiosis is defective, but the germ cells are not progressing into becoming a proper spermatozoa. And in this, because the germ cells are producing adequate amount of inhibin B, the FSH in this population would be normal. But we still like to do FSH in patients with azzoospermia because we want to identify that case with hypogonadotropic hypogonadism, and that wherein your treatment with HMGs and HCG on different protocols could make a difference and achieve a spontaneous pregnancy as well. And again, a lot of patients do not tell us about the anabolic steroid consumption. They will hide that history from their wife, forget telling you that history. So all these patients who could be taking anabolic steroid uses their FSH could be low. And then you may ask some leading question, get that history out and stop that treatment, and probably that could make a difference. Again, when it comes to sperm morphology, it's not so important in a normal semen analysis report. And if you really want to look at the morphology, most of us don't do the Kruger-Strick criteria, but then you can just look at the tail, do a hematoxylin eosin stain and just look at the tail. But that is the one which degenerates first. And there is something called stump tail syndrome, which we forget. We could have learned in embryology earlier, but we just forget about it. And the first hormonal investigation you would be doing in patients with morphological defects in semen or oligospermia would be diabetes, HbA1c, and a fasting PP sugar. And these diabetic patients have a slow vasoperistalsis. Because of that, the sperms spend a lot of their time into the epididymis. And these sperms will have degenerated tails by the time they come out. So there could be patients with partial vasal obstruction also, where the sperm morphology could be defective. And this could be, the diabetes is something which you need to investigate. Remember one thing, the sperm is happiest in the testis, and the second happiest part of the sperm is when it enters the egg. All the in-between part is hell for a sperm. There are millions of sperms competing with each other just to come out of the testis first, go and survive through the epididymal insults and get ejaculated out, then survive the vaginal flora, acidity, then go through the cervix, uterus, fallopian tube, and intense competition with the hormones, calcium, and keep up to their pace just to enter the heaven into the egg. So every atmosphere between the testis and egg itself is quite a difficult atmosphere for the sperm to travel. Non-obstructive azzoospermia could be either necrosospermia, there could be Sertoli cell only syndrome, or there could be maturation arrest. And which patients will have a good surgical sperm retrieval? Younger age patients, better histological picture if the any biopsy report is already available, a FSH level less than 6.5 MIU, and a higher testicular volume, 9.5. To be more specific, I would say there are studies which have been published which say if the testicular volume is beyond 12.5, your surgical sperm retrieval is better. Now let's jump another topic to the endocrine-related male infertility. The American Urological Association guideline says that if you want to do an endocrine test, you'll be doing an FSH, testosterone, LH, a free testosterone, estradiol level. Obviously, you'll be mainly guided by the way the morphology of the gentleman is there. Does he have gynecomastia? Is he excessively tall? What is the hair proportion in him, etc. And the free testosterone, if it is less than 6.5 nanograms, or there is a low testosterone estrogen ratio, and these are the things which you pick up. This could be an endocrine related male infertility. The intratesticular testosterone is responsible for spermatogenesis, and intratesticular testosterone level is very, very high, maybe 20 to 30 times higher than the serum testosterone value. And your oral or parenteral testosterone cannot achieve such high levels in the intratesticular. Rather, they suppress the LH level, in turn suppressing the intratesticular androgens. So somebody is asking me a question about, will you give primorium, what is it? Primorium, provironum, or some drug, testosterone, which is available in India, which is given to for oligospermia. So this exogenous testosterone can reduce the sperm count, and this could exogenous testosterone-induced azzoospermia can also be there. In such a situation, you will just stop testosterone, the exogenous testosterone what the patient is taking, and 90% of the patients will recover with a sperm count of beyond 20 million at the end of 1 year. Within about 3 or 4 months itself, the sperm count starts recovering. I think the same will apply to anabolic steroid use. What about giving clomiphene? 1 minute. Yeah. What about giving clomiphene? Clomid in a patient of low testosterone, normal or low FSH-LH, it's not ratio, FSH and LH. Men with oligospermia with FSH less than 6.5, Chua et al. Has published a meta-analysis which says, well, clomiphene will work. You can even start clomiphene 25 milligram alternate day. Every patient will have a different level. You can do an FSH level again once you put the patient on clomiphene to know the rise in FSH which is taking place. If it's already a low testosterone patient, you can know after 1 or 2 months if the testosterone level has come up, and then you can stabilize the dose. If adequate testosterone level has not come up, you can increase the dose as high as 50 milligram continuously can be given. Letrozole, which is a new drug which can be given in these patients of oligospermia, which is endocrine associated problems. And this works better in patients who are normal testosterone, but with abnormal testosterone to estradiol ratio. And most of the studies which were published earlier talked about an abnormal testosterone and estrogen ratio, which is less than 10. And in these patients, if you give letrozole continuously, which will increase the FSH and more spermatogenesis will be seen. But Liu et al. In 2019 has published an RBM online study that even with normal testosterone estrogen ratio, your giving letrozole would make a difference as far as spermatogenesis is concerned. So letrozole markedly increases the FSH and testosterone. And in the study which has been published, 2 out of 10 oligospermics on letrozole conceived. and 4 out of 17 sperm was ejaculated seen in patients with azzoospermia. So I think it's worth this drug, even I'm not trying using very commonly in my practice. Probably I would introduce this soon. Clomiphene is something which has been there for a real long time, and men with exogenous testosterone supplement had sperm counts, but when shifted to N-clomiphene, the sperm counts improved. And exogenous testosterone, repeating the same thing, that exogenous testosterone supplement cannot restore the testicular levels, rather it decreases because of decreasing LH. Obesity and oligospermia, most of the patients will always go hand in hand. And semen parameters and hormonal profiles in obese infertile males would be problematic. It's commonly associated with oligospermia. And they have high estrogen level, lower SHBG, low testosterone levels affecting the LH, FSH, and GnRH pulses. Now let's shift to what is the use of ultrasound in male genital tract. I'm going to put these papers, these few papers which I'm quoting, I will put them as a good reads on the Fertility Courses Facebook page. I'm sure all of you would love to read these papers. And this is a very extensive study about the ultrasound in male genital tract compared to the male reproductive health, very relevant for all of us. And because not being a urologist, we highly depend on ultrasound, and a lot of us are not doing rectal examination or scrotal examination. Most of the female gynecologists wouldn't be doing it. So we highly rely on the ultrasound to give us that picture. And scrotal ultrasound is very sensitive for diagnosis of obstructive azzoospermia and specific for non-obstructive azzoospermia. USG is more to exclude obstructive azzoospermia. And testicular volume is an independent marker of surgical sperm retrieval optimization, and mean testicular volume beyond 9.5 is a cutoff for retrieval, for surgical sperm retrievals. Patients with hypogonadism, that if the testicular volume is beyond 4 ml, they will have a better response to the hormonal treatment given to them. And 12 months of treatment will show a rise in the testicular volume as high as 5 ml, or some reports have reported even 180% rise in the testicular volume in hypo after 12 months of treatment of HMGs. And what about the guidelines about USG, scrotum, and Doppler? Seminal vesicle, the anterior posterior diameter should be more than 15 millimeter. It should be round shape epididymis, and then this would be an ejaculated duct obstruction would be there if the seminal vesicle is beyond 15 millimeter and round shape is there. And if it is associated with seminal volume less than 1 ml. Prostate and ejaculated duct calcification, again, which will be helping us to reach a diagnosis why the person is having an obstructive azzoospermia. Calcification in the testis could be a sign of testicular dysgenesis. Obviously, any tumor or something can be diagnosed by ultrasound, since we are relying on ultrasound and not clinical examination. If you have a clinical varicocele, which is the thing for your diagnosis and treatment, obviously a color Doppler just to get a documented report can be done. And you should look for a permanent grade 3 reflux, not a grade 3 reflux on a Valsalva maneuver, but a permanent grade 3 reflux. I think when it comes to infertility, we are quite unsympathetic towards the lifestyle changes which are taken place in the community. A lot of us could be having one of these lifestyles as well. And we always blame the problem to that lifestyle change, saying, well, you had to have this problem because you invited it, because you're eating all these things, you're smoking, you're into anabolic steroids, etc. Any problem? Huh? Everybody's hearing? Anil, are you okay?
Yeah, I can hear you.
There's some voice which is coming up. Somebody's to be muted. Now, let's talk about the antioxidants in male infertility. And this is one nice review which has been published, not one of those common journals read by gynecologists. It does talk about all the factors which could be responsible for the oxidative stress. And what we understand after the Barcelona meeting, wherein all these reports and the Cochrane also came with the antioxidant use in male factor, the extensive studies have shown that there is a low strength of the studies which are available right from 1940-30. Plethora of studies are there as far as the antioxidants and to the male factor. There's no clear evidence, and overexposure is harmful. How many of us know that overexposure of antioxidant is harmful to the person, and it can predispose to pathologies. And there is this thing which has come from the animal husbandries, that wherein they are using antioxidants in the cryopreservation media, and they have experimented with the goat and bull sperm. And they said that the sperm spend a long time in the cryopreservation media, and animal studies of adding these antioxidant are quite encouraging, and probably you never know, that may come to our humans as well. And what an overdose of antioxidant can do. I'm really not going to talk about what is the dose of lycopene and carnitine and what combinations and everything. Forget about it. That's all is told to you, and you've read many references. I'm just telling you the other salient points. If there is a high amount of selenium and vitamin E, and this has been reported by the SELECT clinical trial, and this is a cancer prevention trial, it is responsible for prostate cancer, which could develop a little later. So, no point giving months after months of vitamin E. Large doses of vitamin C and selenium, this will decrease the local oxidative stress. And certain amount of oxidative stress is needed for this proper sperm function to be there. And so if the person is there for 6 months of vitamin C, and definitely that would cause problems for the local oxidative stress and the local sperm function itself. Beta carotene, giving large amount of beta carotene could be responsible for lung cancers in smokers. So we need to be very wary about the kind of antioxidant prescriptions which we are going to do to our patients. The Kulkarni has said that there is no point taking antioxidants if you are negative for an oxidative stress test. Believe me, we don't do an oxidative stress test in our practice. And there could be a potential harm to the sperm. And most importantly, you will put the patient for 3 months. Everything in gynecology is due for 3 months. So you will put the patient on antioxidant for 3 months and maybe a little more as well. The husband may request, well, can I take it for more time? And this will waste a lot of precious female time. And back in India, and we'll see so many women having a low ovarian reserve, and we're just wasting the precious female time and pumping in antioxidants to the male rather than taking a certain decision to go ahead with fertility treatments. And this is one nice paper on male oxidative stress and fertility. This was proposed terminology. And believe me, a lot of Indians have contributed to this paper, like Reshma Dhillon Pai has contributed, Sonia Malik Madam has contributed. A lot of stalwarts from the Indian infertility scenario have contributed to the study. And what the study says is that reactive oxygen species is a byproduct of ATP production by the mitochondria in the sperm. So a certain reactive oxygen species is needed for the sperm function, like spermatogenesis, fertilization, capacitation, all that require reactive oxygen species. But because of some pathology, there is an increase in the reactive oxygen species, and the local scavenger system in that man is unable to control it. And this pathological rise then can be genotoxic. And this may be responsible for even idiopathic infertility. So as the oxidative stress increases, you really go from a physiological nature to a pathological picture. And in this study, they have recommended this particular test of oxidative stress, the oxidation reduction potential, which is a measure of MOSI. That's particularly a machine which is available, which gets this test done. And they say that the ASHRAE guideline says antioxidants are not recommended since the measure of oxidative stress should be there. If it is not available, you can't give antioxidant. And then they have given this paradigm, the protocol of how to use this antioxidative reduction potential ORP test and recommend antioxidant therapy for these patients. Definitely, we need larger studies and more publications like this to be very certain about which antioxidant which we are going to use in our practice. I'm just taking you further to DNA fragmentation. I'm sure a bit about of increased amount of reactive oxygen species is also related to the increased DNA fragmentation. Now, a lot of unexplained infertility could be because of DNA fragmentation. Excuse me. And whenever we say that you as a couple are suffering from unexplained infertility, the patients take home a message that, well, there is nothing wrong with us. And I'm sure all the patients who are coming to you for second consultation after one infertility consultation said, well, my earlier doctor said, well, there's nothing wrong with us. But actually that doctor meant is, well, we really doesn't know what's wrong with you. We're not telling them there's nothing wrong. We really don't know what's wrong with you. And then we keep offering treatments like IU and IVF. And various studies which have been done, they say that there could be in this particular proportion of unexplained infertility, sperm DNA fragmentation could vary from 20 to 80%. And if you do sperm DNA fragmentation test, and if it comes positive, probably yes, you may be able to offer a specific treatment rather than offering treatments like IUs and IVF for these patients. Again, there is really, sperm DNA fragmentation is definitely a very special test. A routine SEMEN analysis doesn't talk much about that particular sperm DNA fragmentation. And we really go by the looks. There could be a sperm just looks unhealthy, and there could be a sperm which is very neat looking sperm. And we assume that the neat looking sperm is the best sperm. And probably the neat looking sperm could have a higher sperm DNA fragmentation, could be one which is not going to give us a pregnancy. And so when the studies were done between the sperm DNA fragmentation and the semen parameters, it was not correlating with the morphology or the count, etc. The only thing it was correlating was with motility. Obviously, that has to be true, because with sperm DNA fragmentation, your mitochondrial DNA, everything would be a little defective, and your motility could be affected. And when the odds ratio was compared of with sperm DNA and of motility to fertilization and sperm DNA fragmentation, the odds ratios are compared, both were very significant, but the significance with sperm DNA fragmentation was all the way to 24.81 compared to 4.18 of motility to fertilization odds ratio comparison. So sperm DNA fragmentation is definitely very specific when it comes to fertilization. Then the next question is, who should undergo sperm DNA fragmentation testing? I would say maybe everyone, nothing wrong. You could have issues with it, but I would say go ahead, do it. Because the traditional tests haven't improved our treatment protocols anyway. We are, like last 10 years, we're giving the same treatments. We're giving IUIs and IVF and XCs, for the same, some of us could be using PIXI, whatever. And we really don't know what further the test is going to be, should be done. So sperm DNA fragmentation could be that one additional test. But again, it is not recommended for somebody who is definitely scheduled for ICSI. Well, it wouldn't, because most of the patients with sperm DNA fragmentation will need ICSI. If you're anyway going to do ICSI, that wouldn't make a difference. One of the problems with sperm DNA fragmentation testing is what test to do. Comet, tunnel, sperm chromatin, halo test, CASA, what tests are you going to do there? And there exists a lot of confusion about that thing. Whenever you do ICSI, it will work best with sperm DNA fragmentation cases, and we put the sperm in heaven straight into the egg. And there is some ability of the egg to repair that sperm DNA fragmentation damage, and which will determine the progress of fertilization and the pregnancy. And what could be that threshold DNA fragmentation, which is repairable by the egg? And this is also going to be egg specific. Because the eggs of an older woman will be having a lower threshold of repairing the sperm, while eggs of a younger woman would have a higher threshold. And whenever you use ICSI, you have fertile eggs. What I mean by that is, in ICSI, you know the egg in front of you is a metaphase 2 egg. In IVF, you really don't know what egg is there. That's you will come to know after 18 hours after you do denudation. And in IVF, the sperm is going to be in the media for about maybe 4 hours to 18 hours till it makes through that corona and everything and goes and achieves fertilization. It's really firefighting with all the ROS in the media before it really entering into the egg. And when it comes to its ICSI, it is one sperm and one egg. So the egg just gets one sperm there. And egg will typically act like a female, spending all her energy and skill repairing the sperm and making it neat and clean. And that's what we are observing in the lockdown period. Yeah. Now, I'm going to present to you just 2 or 3 meta-analyses. But before we really go to the meta-analysis, I don't want to use a lot of statistical jargon. So I'm just putting this small thing to make you understand what a meta-analysis tells us. There is one central line in the meta-analysis forest plot, which is a line 1, which is a line of unity. Now, this is one study which is about a certain antihypertensive drug decreasing the blood pressure by about 4 millimeter, and how you take the clinical information from that. So, if your confidence intervals are away on the right side more than the relevance limit. Relevance limit means, like whenever you're doing a study, like when Richard Legros did a study between letrozole and clomiphene in PCOS, he said that there should be a difference of 10% to say that this significant difference is there, and they could achieve a maximum difference of 8%. So if that, once that is determined, that will also be done on power calculation, everything will be done. And if the whole confidence interval is beyond that reference limit, then this is like B, which is statistically significant and it's also clinically relevant. That's something which will apply in practice. But if it is in the reference range and it is on the right side of the unity line, then it is statistically significant, no doubt, but it is not clinically relevant. And suppose the confidence interval is big enough. This typically happens with the smaller studies, and the diamond of the smaller study would be very small, and it is crossing the line of unity. So it is still clinically relevant because it is making difference to a large number of population, but it is not statistically significant. So on this basic knowledge, now we're going to see some forest plots of the different meta-analysis. Now, this is one about the DNA fragmentation pregnancy losses, and this is a systematic review which has been published. And they have really gone through all the studies and different methods of DNA fragmentation testing, like SCD, CASA, tunnel, all these were assessed. And there is a clear association of sperm DNA fragmentation is associated with unexplained repeated pregnancy. All these patients are patients of idiopathic repeated pregnancy losses, while all the other tests are normal. So I think this is one class of patients I think we should be testing sperm DNA fragmentation. Second is, this is whether sperm DNA fragmentation has an effect on pregnancy and miscarriage after IVF and intracytoplasmic sperm injection. And this is a study in 2014 by Jing Xiao. There were more than 3,000 cycles were tested. And this is in correlation with the earlier meta-analysis published by Zinni and Robinson. If you do IVF, the odds ratio is 0.66. That means if you do IVF for a patient who has a sperm DNA fragmentation, it doesn't make a much difference. When it comes to ICSI, your odds ratios improve, but look at the miscarriages. There is definitely significant rise in the miscarriages, even if you do an ICSI with sperm DNA fragmented sperm. So definitely that is some good information which we are deriving. A lot of us, when we have cryptozoospermia, like in a pellet detection after semen analysis, if you're doing a pellet detection, you're finding 1 or 2 sperms. Very infrequently, maybe in 4 samples, you're finding 1 or 2 sperms. Whether you should be using that particular sperm or you should go for a testicular TISA and use a sperm. And probably we think that there could be a sperm high DNA fragmentation, there could be low motility, and it could be difficult to use it or difficult to freeze also. And the patient is thinking, please avoid a TISA for me, and it could be cost cutting as well, and they would be more conservative attitude. And the results truly agree with the patients that the ICSI pregnancy rate is 0.53, odds ratios, fertilization rate, this ratios are 0.91. So there is no difference whether you do an ICSI using that sperm or at the end of pellet detection, or you do a TISA ICSI. I think it's all the same. Now let's come to what sperm selection methods which we're going to use in our practice. And sperm selection method really is this is come from a Danny Saka's paper. This is one more good read, real good read for male factor infertility. I'll definitely post this across to fertility courses. And he says that there's a focus on current sperm selection of what we understand of the sperm travel. And we have tried to make our selection procedures match these protocols. And in our routine IUI, and these are 2 nice papers by William Omelette, and he talks about the homogeneous semen sample and a meta-analysis of semen quality and the prediction of IUI cycle. If the inseminated motile count is beyond 1 million, the morphology is beyond 4%, the total motile sperm concentration is between 5 to 10 million, and total motility is beyond 30%, well, it doesn't make a difference. The pregnancy rates are always good. But the best pregnancy rate are between 5 to 10 million. So, this tells us that if the total motile sperm concentration is between 5 to 10 million, which a lot of our oligospermics would be, we can still recommend IUI because IUI has the best success rate with that TMSC. Then the question is, will you do a density gradient, swim up? I think all of you know the pros and cons. I'm not going to go into those details. But what I want to convey you is when you do a density gradient, the mature sperms will go to the bottom of the tube and the immature ones will remain in the upper level. So the DNA fragmentation of the immature sperms will not be there. But if there are DNA fragmentation of mature sperms, they will still get selected. And when you use a swim up method, and now this swim up method, you're taking all the sperms which are coming out. So this swimming up will highly depend upon a very intact mitochondria and a good DNA function. So some sperms who will have an incipient factor, so DNA fragmentation is there but not very bad, which will still move, will still get selected. So in both these methods, the take-home message is your DNA fragmented sperms do not go away completely. You still keep selecting sperms with certain amount of DNA fragmentation. So this method, which is now introduced, is microfluidic. And one of the papers which has just been published in 2017 in Molecular Human Reproduction, is a very interesting paper. And what it says is the sperm DNA fragmentation is less than 1% when you go do a microfluidic sorting. So microfluidic sorting is all about making the sperm force through, travel from one distance A to distance B. When the sperm is made to travel that distance, which actually happens, from the tube. The sperms which are able to travel but cannot last longer because there is a certain amount of DNA fragmentation, they will not be selected. So only a good DNA, integrated DNA sperm will be selected. So this is one technique which we should be looking forward to with kind of results. Obviously, the results with IUI and ICSI are yet to be published widely, and we would look for these papers. Now, what about testicular sperm? What does the meta-analysis tell us? In non-obstructive azzoospermia, should you be doing a micro-TC, a conventional TC, or a TISA? Obviously, the meta-analysis says if you do a micro-TC, there is 17% more chance of obtaining sperm compared to a conventional TC. And conventional TC has 2 times more than that of a TISA. So I think the jury is clear that if you have the facility of micro-TC, if you are having that microscope with you, operating microscope, do use it. Otherwise, well, you would be depending on conventional TC, as most of us are probably today. Then, if morphologically the sperm is bad, semen is bad, and there is a severe case of teratozoospermia, will it affect the blastocyst formation or live birth rate? This is a retrospective analysis of around 1,000 cases. See, this hardly matters. If there is a morphologically very bad, there would be few sperms. You will need 2, 3, 4, 5, 10 sperms, and the embryologist is good enough to select morphologically normal sperm. And so that sperm, which is used for ICSI, is just not going to be a representative of the total semen, all the sperms in the total semen sample. So doing an ICSI could be the treatment for this, and well, making the initial assessment of morphology quite irrelevant in our practice. This is one nice trial which has been published called a HAP-SELECT trial, published in UK, and it was performed for 2,700 couples, wherein they were divided into 2 groups. One was about 1381 went for PIXI, that is hyaluron binding sperm. So HAB is for hyaluron binding sperm, and the other 1300 went for about conventional ICSI cycles. And what they found that the live birth rate, where there was no difference, odds ratio is 1.12, and confidence interval is 0.95 to 1.34. Whenever the confidence interval is crossing 1, is 0.95 to 1.3, it's crossing 1, then remember this is not significant. And the birth defects are also same in both the groups, and so they could not say that that using a hyaluron binding, using PIXI, has any more advantage than the conventional methods what we are using. And there's a SWOT analysis which has been published about the testicular sperm for intracytoplasmic sperm injection with patients of high sperm DNA fragmentation. And they say that the sperm chromatin compaction is going on by the time the sperm is going through the epididymis. So when the compaction is on, there is a reactive oxygen species injury, which are secreted by the epithelial cells of the epididymis, will affect it. And also could be because of sperm activation of endonucleosis from the sperm itself, which could affect the sperm directly. And hence, the one which is an ejaculated sperm could have a very high DNA fragmentation, and testicular sperm wouldn't have it. And he said, well, that is an advantage, and you could use a testicular sperm. So who are the best candidates then to do a testicular sperm and ICSI? Varicocele patient will have a high sperm DNA fragmentation. Well, if you're not offering surgery, you may go for this. I'm not touching surgeries at all. That's a very different and completely separate topic. But I just want to tell you that there are some medical treatments which are coming up. There is a drug which is called, it's one of the celecoxib's derivatives. I think it's a sanacoxib or something. I'll put it on the fertility courses. If a long-term treatment can improve the varicocele semen parameters. So probably in the future, we could be looking for treating varicoceles medically as well. Epididymal infection, if it is there, well, testicular sperm would be better. A male accessory gland dysfunction infection, again, these are the ones who will have a very high sperm DNA fragmentation. Post-vasectomy reversal, I think we don't get so many patients with this. Patients with a high leukoospermia, which has been resistant, not being treated, not responding to treatment, and patients who have repeated ICSI failures and cryptozoospermia, well, probably you may look at the testicular aspiration of the sperm. And what are the threats for this SWOT analysis? One is many times in a non-obstructive azzoospermia, we will be taking multiple biopsies, and that can lead to infection. Suppose you hit the testicular vessel, which is an end artery, there could be hematomas. I've witnessed one with one of those clients. There could be multiple biopsies. The most important is if you take multiple biopsies and the patient has undergone 2 or 3 TC cycles, these multiple biopsies will remove Leydig cells as well. And over a period of time, once the Leydig cells are removed, over a period of time, this male can have hypogonadism in the future. And then this is another, I think this is again, Anil highly recommends this part. There's a Gulam Bahadur study which is published in 2016 on RBN Online fertility courses. Dr. Goody has done one video on this, that if you take a repeat semen sample after 40 minutes for the first sample, there is a better motility, morphology is better, and they have low DNA fragmentation. And this is another study which has been published earlier. And this is the only study probably which talks about these sperms. They took 3 samples every 2 hourly from the men, and they did report a high DNA fragmentation index. But the replication has been done by many more authors besides Gulam Bahadur, and the DNA fragmentation index has been little lower in the repeat semen sample. So I think that's something which we could be looking in. And with the earlier studies and meta-analysis telling us that the total motile sperm count concentration between 5 to 10 million is good for IUI. So suppose you're having somebody who's having a total motile sperm concentration less than 3 million all the time, and probably they are going to go for ICSI, would be better, and they cannot afford it or they want to postpone it, and they are requesting you, can we go for a trial for an IUI? Probably even this methodology, having two semen samples collected, and then if the total motile sperm concentration of the pooled semen is more than 5 million, probably that IUI could be possible. Well, thank you so much. Thank you very much. You can ask any questions. I'm sorry, it was a little bigger presentation. Thank you very much.
Yeah, I think there were a few questions asked. I think it didn't take you an hour. It took you around about 40 minutes.
Okay, I thought I would go a little big on this. Yeah. I think Vidya is asking about letrozole dose and duration. Yeah, the letrozole 2.5 milligram. I think minimum about 2 months, but you can go about 6 months.
So if you have any questions, just put it on the chat. It's
Chaitanya
easier.
is asking, will using DNA fragmentation in ICSI may help to use a sperm sort or other methods available to choosing sperm? Yes, Chaitanya, I think I do agree on that. When you're doing ICSI especially, suppose you want to use the annexin bead magnetic activated cell sorter, I think that makes sense. It is one part of the semen DNA fragmentation methodology, the apoptosis, which is there, and if can be managed that way. But obviously the DNA fragmentation has different etiologies. There could be immature sperms also with DNA fragmentation. I don't know to what extent they would be sorted with max. The experts can opine, have their opinions to me.
I think one of the biggest challenges of DNA fragmentation is that we haven't yet proved whether DNA fragmentation is a standalone test, and DNA fragmentation changes. So it changes. So if a man ejaculates regularly, the DNA fragmentation starts going down. So and equally, you don't know the impact of infections. And what we have forgotten is that though we have a better way of controlling syphilis, gonorrhea, more men are infected with the less serious sexually transmitted diseases. So we don't know exactly what's happening, and the incidence of prostatitis also starts rising. So all the cell sorter, we don't use it in the UK. We don't use much of it in the UK. So, and I think they're sold quite extensively in India. And so I don't know it. So often, let's go back to and look at cardio mapping. And if you see, where do a large number of abnormalities in aneuploidy come from? And it seems to come from the egg rather than the sperm. At present, it seems so. So as we move over from a different platform to cardio mapping, probably we'll start understanding how much of a role that the sperm play.
I think what should be the post-wash TMSC that is called insemination motile count IMC, should be more than 1 million. That's what the omelette meta-analysis is telling us. Role of varicocelectomy in grade 3, grade 4 varicocele. I think as I understand from the ASRM and AUA guidelines, varicocelectomy or varicocele ligations will be done for somebody who is having infertility, low sperm count, and a palpable varicocele in this. So now, will you do a varicocelectomy for somebody who is a grade 3 or grade 4 varicocele on ultrasound alone? I don't know, the urologist would be a better person, but I don't do varicocele. In my practice, I don't do, because the entire decision is on varicocelectomy, is on, for me, the decision more relies on what is the female factor. All these conservative treatments to the male factor, I will give only if the female factors are good. Am I having a good ovarian reserve, young lady? Well, I would give these treatments. For somebody who is compromised with the ovarian reserve, all these conservative treatments just go away, and probably we go to ART much more faster. Which DFS test? I think Dipan is asking what DFS test we recommend. Yeah, Dipan, what has happened is we need to outsource our DNA fragmentation test, because in spite of having a CASA in my unit, I've not been able to offer. I'm just offering sperm chromatin dispersion as a DNA fragmentation test, which doesn't have a huge strength, I would say. Tunnel and Comet could have a better strength, but I'll have to outsource
Sachin,
it. Outsource it. Yeah.
Just 1 minute. I'll just share a screen.
Yeah.
And I'll show you, because I've done this talk on DNA fragmentation for miscarriage. So I'm putting that on a bit later. Just give me 1 minute. So so let's have a look at which DNA fragmentation tests are there. So at present, you have 4 major tests, and no one is using the same test across the world. So you've got sperm chromatin structure assay. That's one way of looking at DNA fragmentation. And then looking at a tunnel assay, that's terminal deoxy, whatever, the longer the name, the more difficult. Then you got the sperm chromatin dispersion, and you got the Comet test. So in simple terms, if you see, this is the review which I've written, and I'll present it sometime later, and there doesn't seem to be much correlation into how they measure it. So when you start using the test, I'll say find out which test is being used, and every test is on a different platform. So, what we don't know at present is exactly, which tests are being used. So it's again, there are different tests in different countries. So, we use to some extent the Comet test. I don't know what you all use, Sachin.
No, all that has to be outsourced. I have to send it across, because it's we don't have it in my lab. In my lab, I'm just using sperm chromatin dispersion, but it's not one of those.
So in fact, and that's one of the problems when you say, what should be the DNA fragmentation? And I know I've seen an equal number of men with such horrible DNA fragmentations who got pregnant naturally, and equally with completely normal DNA fragmentation who had required ICSI and have a very poor fertilization. And in very simple terms, let's put it this way, it's difficult to try and comment on sperm, because we just don't know. We've ignored investigating men to a large extent for many, many years. And I think we have lost the skills of trying to find out what's going wrong. And because IVF and ICSI come so easily to us, and ICSI has become a way of treating male infertility, though it's not a treatment of male infertility, and ICSI is overriding that defects, and we are lagging phenomenally behind how to treat male infertility.
Yeah, actually, a lot of these DNA fragmentation issues are there because we really don't know how the oocyte is going to perform. And since the oocyte keeps repairing the DNA fragmentation, and so should we, let's say there is a couple with a DNA fragmentation of, let's say, 30%, and we use donor eggs and use a same sperm, and probably we may get a good fertilization. It also depends. Also, we need to have a study. What is the threshold of the DNA fragmentation which is manageable by the egg, and that particular study is just not available to us.
I think Indra asked for consecutive sample. Again, we know less about consecutive samples.
Thank you, sir.
But the data coming through suggests that you can get a more motile sperm. And so, what do? And I tend to say, if somebody's producing, I have a cutoff of total motile sperm to about 5 million, because that's where I think results start looking better. And what we will end up doing is, if somebody gets about 2 or 2.5 million motile sperm, even though that is good, it doesn't give you much good results. So in those cases, I'll try and say, let's combine samples. So the abstinence, I'm going to show you, while Sachin answers that, I'll try and get you an old talk, which will probably tell us what's happening. So Sachin, you can take that question.
Yeah, this is about abstinence. You know, the WHO said the abstinence could be between 2 to 7 days. Then does it mean that the sperm after 2 days and the sperm which has stayed in testis for 7 days, or the only male genital for 7 days, is it going to be the same? Or will it perform same? It comes to from the fertilization point of view. And Chris Barrett has nicely says that, well, the wakey factors which are there of the semen which is produced after 2 days of abstinence, that after 7 days could be different. And so the studies which have been published, there is a nice paper of technique of IUI where we need to change. And they have really evaluated the 2010 WHO criteria and what needs to change. And they said that if the abstinence period is between 2 to 4 days, that does the best. So 2 days of abstinence is what I follow in my practice.
Okay, I'm going to share a screen.
Mm-hmm.
So what about the abstinence? I'll show you what the American Society came up with this study. So initially they said that if you have abstinence for more than 5 days, it seemed to affect sperm count. And again, if you say, again, there's evidence that shorter the abstinence of 2 days associated better sperm. So what did they do? And this was done in China, and that's the only country where you could do it probably. And what they did is they studied 10,000 semen samples and on count motility, and it remained normal after daily ejaculations. So in fact, normal daily sex does not worsen sperm. Then again, if you look at how often do you have, if you have daily sex during that period approaching ovulation, the chance of pregnancy is the best. And as you tend to have sex less and less, the chance of pregnancy tends to start going down. So the simple question which I would always ask is what is this abstinence based on? Very poor evidence. And WHO's evidence is way much late. And I think it's the simple question is, if there's the more times a man can have sex, the better for fertility. Yeah, I think Parag is absolutely right. 2 to 3 times a week is absolutely perfect.
And this is about ICSI and IMSI. You do not have to worry about DNA fragmentation. True, I would say yes. If it is more, it can be overcome by ICSI. Will it be overcome by ICSI? It entirely depends, as I told you earlier, it depends upon the egg quality of the lady. So I think when we have sperm DNA fragmentation positive, we should be giving good antioxidants to the lady also, so that her oocyte quality and whatever improves, and that could be more useful as well. Well, thank you so much. Parag, should we do one on erectile dysfunction sometime?
Anytime you say. I think we should have to call somebody like a urologist for that, because I will be having a really inadequate knowledge to talk about anything beyond sildenafil and cadalafil.
In fact, many urologists also, I think those who do andrology probably are better suited for this.
Yeah.
Okay, this is one thing which we have not taken. When to advise karyotype for patients of male factor? See, the karyotypic problems are of different types. Like commonly what we test is for Y microdeletions. They could be mutations. Okay, so when you would be doing this, I think it is all related to the semen parameters. If it is Azzoospermia, there is 10% chance that there would be a karyotypic problem or a Y microdeletion would be there. If it is oligospermia, I think the chance comes to around 5 to 6%. And in a normal semen analysis, the chance of having a genetic issue is 1% or less than that. So I think the karyotype is something which will be done for all patients of Azzoospermia to know the prognosis and do the genetic counseling for these patients. Well, thank you so much. Anil, should we close?
Yeah, I don't know unless there have been any questions. So I'll speak to Amit, and I think next week he's got some talk on endometrium, on saying what should be the ideal endometrium, and I've got some talk on at what level of endometrium.
Anil, I'll just let me take this question, Rajguru. are there any effects of sildenafil and tadalafil on sperm quality? Yeah, definitely. There are nice publications, about 2 or 3 publications which have been published, that whenever you give sildenafil and tadalafil, there has been an improvement in the semen parameters. So, this is one study where they gave sildenafil, and after 1 hour, they did an zona binding study of the semen, and they noticed a positive difference in the zona binding after giving sildenafil. But most of us are not using sildenafil because it's an on-demand treatment, and which is not very effective. Most of us are using tadalafil. And tadalafil, the first study when they did, well, it says that the tadalafil doesn't make a difference, but then the publication of studies says that using a long-term tadalafil improves semen parameters. So my suggestion would be, if whenever you're giving antioxidants or any treatments for your patients of male factor infertility, do give a tadalafil. And taking carnitine or lycopene, patient is spending a lot of money, not making any positive difference. But that small 2.5 or 5 milligram of tadalafil will improve his sexual performance. He will trust you more with the treatment. And anyway, you're doing good ethically because it will eventually improve the semen parameters as well.
With antioxidants, I think there's a huge data now. Everyone seems to be interested in reactive oxygen species. And if you have a look at antioxidants, we just don't know the data of whether antioxidants will be dangerous. Correct me if I'm wrong, Sachin.
Yeah.
The data is not there because antioxidants are classified as supplements. And supplements are almost always non-regulated. So in the West, anybody can sell supplements. So as soon as supplements are non-regulated, it's very difficult to do research. So at present, it seems that they are safe, and it seems that it's very likely that we don't know at what level you should be, how much you should be taking, how long you should be taking. Linked to fertility courses, there's no such link to fertility group of fertility course. So
actually, I just came across this case report. This was a case report about this husband, and you know how men are always men, they say, and they are forgetful. So this person would forget taking antioxidant supplements, and whenever his wife would remind him, maybe after 5 or 6 days, he would suddenly take all the quota of the days he has missed. So this gentleman would suddenly take a large amount of dose, and he was taking a large amount of B complex, vitamin B6. He will take a large dose, and that was giving rise to some amount of muscle weakness and dizziness, and he wouldn't be able to do a good sexual activity. And that was projected as a case report. So, we need to really go into all those small things when it comes to antioxidant treatment. Most important is there a measure of oxidative stress? That's a very scientific question. And if these authors, I've really checked on all the authors, I think we should just speak to these people who participated in that Moses study. And if they have a machine which is telling them that there is an oxidative stress present in the semen sample, and if we can get that information, probably then the life would be much easier. Well, Anil, thank you so much. It was lovely and a lot of questions, and thank you all of you.
Okay, so it will be, again, we'll decide on a topic, and it will be, so if you have any questions, I've got about 3 or 4 cases to discuss, but I haven't found time. The question is, the lockdown has given us a lot of time, but sadly, the more free time you get, the less work you end up doing. And in fact, my productivity has become so low during this lockdown that I'm a bit worried. So what I would say, if you have any cases, send it. And somebody sent me 3 cases, so I'll probably work on it over the next 2 days. And what we could do last time is, I've got 2 cases of poor responders, and with an AMH less than 3 pmol, so it's probably 0.3 in your books, and both of them now are pregnant, and that is because we use alternative protocols. And I believe that some of the protocols which we use, fixed protocols, just don't seem to work in poor responders. And I'll always say, think outside the box for poor responders, think differently, and use your physiology, knowledge of physiology to look at poor responders. So at some stage, I can do this 2 or 3 cases, and I can go back into looking at how follicles develop and how they vary in development, and how you can literally go for the best possible time to stimulate. So I'll do that in some stage when my productivity gets slightly better. But otherwise,
Yeah, and I'll also, with those poor responder, I'll also discuss this paper published in Journal of Assisted Reproduction and Genetics in 2020, just last month. It's a beautiful paper on the new meta-analysis on geostimulation. I think we'll just go through that paper also.
So next week there's already a video coming up on Wednesday, which Sachin has done a talk on luteinization during IVF. And the reason why that's important is because why do follicles collapse and why do follicles give less eggs and why does progesterone rises? And that's a brilliant lecture which Sachin has done, and that's going on Wednesday. And I think I've put another lecture on what are the success rates of IUI with one tube being open. And I've looked at all the evidence because patients come and ask us, what is, I've got one tube that's open and IVF or IUI, and there's one on what happens to sperm with COVID. So all those are coming up in the next week, 2 weeks or so, but we'll meet up next week, same time, and we'll decide on the topic. So thank you very much.
Okay, thank you. Bye-bye. Take care.